position 1, then you have a better surgical outcome for palatal surgery. But if you have a higher Friedman staging, then the surgical outcome for palatal surgeries is quite poor. And this was proven many times by Friedman over a few years, where they showed that the higher the stage of Friedman, the surgical success for palatal surgeries, again I repeat, for palatal surgeries reduces. Now we have done history taking, we have tried to figure out where it is, we have done a clinical examination with Friedman tongue positioning and everything. Does that give us enough information to diagnose OSA? Not really. That's where, I mean, there are multiple studies that will tell you that if you do not do a proper identification, you are not diagnosing OSA. And then you go on to the next step of trying to evaluate where exactly the obstructions are. So with the scopes, we've got the best of scopes nowadays. You can do an awake FNLP in OPD with a Muller's maneuver. You can do a sleep nasoendoscopy, which is not possible in India, so we don't even want to discuss that. And there is DICE, which I will be discussing. Now, in the awake situation, when you do it with the scopes that we have, it's so easy to diagnose simple adenoids also in an OPD. It is also easy to look at the collapse of the airway, not just in the anterior-posterior direction, but also medial-lateral direction. That is the important part. Whereas nowadays, we don't even need X-rays, but just a simple scope in the OPD, a pediatric scope also tells us and shows us the kind of an obstruction you have at the choana. So this is something you can do at your primary level in the OPD itself. There's never a problem there. Amongst the radiological examinations, once upon a time, cephalometry was done in those days. And I say once upon a time because we don't really use it nowadays for two simple reasons. One is that it's a static evaluation and happening in a sitting or a standing posture, whereas an OSA is a situation which is to be dealt with at night, I mean, in a supine position and a dynamic evaluation, not just in a static position. So it is now restricted only to the dental and the maxillofacial colleagues who want to actually find out what are the bony measurements and how much is the bony airway. We don't resort to a cephalometry as ENT surgeons at all. The thing that we can do is the dynamic MRI, which I have been actually propagating almost 15 years back and things, but it hasn't taken off for various reasons, which I will discuss. What happens in a dynamic MRI? Nothing very different. So basically, it's just like a routine MRI. So when I started off maybe 18 years back or so, the MRIs didn't have the dynamic software, and every center had to buy something worth about 55 or 60,000 bucks at that time to evaluate the motion. But now every 3 Tesla plus machine has the incorporated software, and you don't need to do anything differently. So what we tend to do is in my center, we call the patients at night postprandially. So already it's a sleep apneic patient who has got EDS and who is very sleepy anyway. But what we do is call them about an hour after their food. You put them in the gantry, which is like darkened and air conditioned, and that is the time when most MRI centers are not working very much. So you have a tie-up with the MRI center and tell them that you let the patient sleep for 15-20 minutes inside the gantry. And there is a class 4 person, a mama, maushi, or whoever sitting there waiting to hear the snoring that starts off. And the minute they hear it, they come out and tell the technician, and we start the recording. Now, what is important here is the counseling that needs to be done before you get the patient for a dynamic MRI. They have to be counseled that it's 15-20 minutes. And once they fall asleep, they'll probably start hearing the sound of the MRI very loudly. And they should not get up with a start. And they should just lie peacefully, lying down there for 15-20 minutes, in which you can do the recording. And this is how the recording happens. In a sagittal section, you can very clearly see at what level of obstruction. It could be at the level of the hard palate, soft palate, base tongue, or epiglottis. So in the vertical direction, you see the nose, you see the nasopharynx, you see the palate, you see the tongue base, and you see the epiglottis. And at the same time, you can always see
Uh,
the bony structures also. The same situation, when you do it in an axial scan, you will be able to see the anteroposterior and the mediolateral diameters. And because it's an MRI, you can actually record the diameter. You can record the measurements. Now, what happens is this axial section can be taken at the level of the hard palate, it can be taken at the level of the soft palate upper end, or at the base of the uvula, at the base of the tongue base, at the epiglottis level. So, multiple axial scans from vertical top to bottom can give you the diameter dimensions of the airway completely from top to bottom. And that is why this is a more objective way of evaluating the airway, because then post operatively, so these are the levels at the soft palate, base tongue, epiglottis, you have AP and mediolateral dimensions, so that post operatively you are then able to kind of uh, correlate what you have done versus what was the situation pre-treatment. Now the cons that come with it are basically that people talk about claustrophobia, expensiveness, and the non-glamorous part. I'm sorry, I'm again getting a lot of disturbance, so I really can't understand what I'm saying. Would I request the moderator to please just check in and ask them to keep their mics off? Sorry. Right. So when you look at these obstructions at different levels, even those patients who are sometimes not able to undergo a DICE, this is a very easy way to do it because it does not put the patient through any invasive evaluation. Or if you want to note an already previously operated patient, then the dynamic MRI becomes good. Now, the way to look at it is it's not really claustrophobic if you kind of explain to the patients and do it properly, because every day hundreds of MRIs are done in every centers across the country. And obviously, there's not much claustrophobia there if the patients are well counseled and kept. The only thing is it's a little not glamorous because we as surgeons have this crazy surgical ego where we want to do everything, and we don't want to just sit and look at a report and then go ahead and just give our diagnosis and treatment based on somebody else's report. And like I said, this is where you can make out the difference between the pre and the post and airway, and you can measure it exactly where it is. Then the other important investigation is the dice. Is a dice that we tend to do. And I'm going to make some very important points on dice today. So I would like you all to please listen to this part of it very well. Now, DICE is an invasive procedure that needs to be done to find out under anesthesia where is the blockage. So, a consent becomes extremely important in such kind of people because this is an invasive procedure where the patient is going under anesthesia. So, you need to have a very specific written consent explaining all the pros and cons and the dangers of a DICE to the patient. You cannot do the dice, and the consent becomes very important because you cannot do a dice and immediately go ahead with the next surgery, right? Because then that way the purpose of dice is lost. Now, if you are planned a surgery already on a Monday morning and you're doing a dice on Monday morning and going in with the surgery, then that means your dice did not help you to decide on that particular surgery. So then what is the use of dice? That is why even medico legally, you have to do a dice at least a day or two prior, discuss with the patient, not just the relatives alone. You can't say, I did the dice, I went outside, spoke to the relatives, and then went ahead with the surgery. Medico legally, the patient has to know the findings of the investigation. Patient has to be discussed with what is next planned, and the patient has to give you the consent. So your dice should never ever be done on the same day as a planned surgery for that patient, except for the time when, let's say, you're doing a nasal surgery or septoplasty for a multi-level patient, and please listen to these statements of mine very carefully because this is where otherwise misunderstandings occur. If you have a multi-level obstruction which involves nose, palate, tongue base, and epiglottis, and you're doing it as a first stage of doing only the septoplasty under GA, then before the septoplasty, you can do a DICE and go ahead with the septoplasty, but not for any other reason that you will do the DICE and go ahead with any other procedure on that same sitting. Right? Second important thing is that it has to be done in an OT setup. Do not take DICE lightly. You're already dealing with a compromised airway, and if the airway collapses, you will not be able to intubate and get that patient out. And that is why the importance of intubation tracheostomy consent becomes very important. And you have to have preparedness for all of this before you take the patient up for DICE. It has happened many times when sometimes just a little bit extra propofol or a little bit extra sedation has caused the already compromised airway to collapse, and then people have not been able to intubate and has created problem. I know this because I also deal with medical legal issues as one of my fortes. The other very important point that you have to keep in mind when you're doing a DICE is make sure you have an extremely trained anesthetist with you, and you should only work with two anesthetists when you're doing a DICE. Both of them equally trained. The second one, why? Because sometimes you may have the first one not available to you. Whether you're in an institute or you're in a private practice, only two people that you should have worked with regularly so that they know the dosages of the medication, they know exactly what level of anesthesia you need to be in, and they know and they are well trained in being able to secure the airway for you if it is needed. So this is extremely important as part of the team. Do not try to just randomly, okay, I've posted in the OT today, my regular anesthetist is not there, so I've got this anesthetist to do. You should rather postpone the DICE to some other time. This is not in any way to take away from the skill of all the anesthetists, but just as we do specialized work, if we have somebody who's well specialized with DICE, then your planning and your execution becomes very easy. There is something called as a BIS monitoring, bispectral index monitoring. It has issues with the cost of the equipment and the disposables, but that is something that we do need for DICE if you're going to do it, because it gives you the level of the depth of anesthesia. You can't go down too deep into anesthesia because then the obstructions would change. And you can't be too light because again, then the obstructions would change. So a BIS monitoring helps us to figure that out. Thus, once you've done the DICE, it's also important to interpret it. You just can't do it and forget it. So one of the analysis that is there is that we used to first identify the level of the collapse vertically. So that would be either at the level of the palate, oropharynx, tongue base, and larynx. Secondly, we used to do a talk about is the degree of collapse, which would be either partial or complete. Because if it is partial, then you take it as 1, complete would be 2, X was not visualized. But now what we do is we have a third analysis where the type of collapse is also brought into the picture, where we talk about AP collapse, mediolateral collapse, and concentric collapse. So this way what happens is we have now started classifying the DICE what do you say, reporting like the TNM classification that the cancer surgeons use. So you do a V2C, O2L, T2, E2AP. So if I am talking to Dr. Suresh there in Trivandrum, and if I give him like this kind of a TNM classification, both he and I know exactly what we are dealing with, rather than talk vaguely that, oh, I thought this one was collapsing, that is collapsing. That is not very objective, it's very subjective. But this kind of reporting makes it very objective. And at the same time, it also tells me. So, for example, if it's a V2C, I know it's a velum complete concentric collapse. And then I know that I have to do something that will help me pull up the soft palate and stabilize the lateral wall, plus a tonsillectomy would be needed. Similarly, when I'm dealing with the O2 lateral wall collapse, that's the stabilization of the lateral wall. And T2, which is a complete collapse of the tongue base, then I know I have to do something to the base reduction, either with coblation, radiofrequency, or TORS. And the same thing with the epiglottis, that I would either need to do epiglottopexy or a epiglotectomy, supraglottic epiglotectomy. So when you kind of give this kind of information, things become very easy for us to deal with. DICE also has limitations, just like MRI and every other thing, that we don't know the depth of the sleep issue. And every time whenever I'm invited to a chest forum, this used to be, not anymore, but this used to be their biggest ace of spade card against me, by telling me that when you're doing a DICE, you don't know at what depth you have put the patient in anesthesia, and therefore there are issues. Interpretation, like I said, now has become easy. Cost is an issue because it's a complete invasive procedure going into the OT, out, plus it's a daycare admission. You can't just send the patient home in 1 or 2 hours. And the biggest problem is reproducibility post procedures, because again, 1 milligram extra of the drug pre or post and things like that, and the whole collapse patterns will change. So there are limitations to DICE. But to take away the limitations, what the chess people used to tell me, we started doing what is called as an advanced DICE, where on one side I'm doing the DICE and the patient has got an intra-procedural PSG lined up, and I'm also seeing the stages of sleep on one side. So when I see that the patient is in REM stage 4, that is the time I'll see where exactly is the obstruction and note that. So this was something which helped me bypass the problems that were pointed out to me by the chest physician. But I think over a period of years now, this is almost 7, 8 years back that I was doing this. I think in the past post-COVID era, I have not really been doing much of this because it doesn't make that much difference to our management. And we'll discuss that at a later time. So when you do a DICE, make sure your safety concerns are very much in place, because that is extremely important. I've explained to you why the timing of DICE is very important. One is not only just medical legal, also from the point of view of you to be able to understand that you have to take decisions based on DICE and not just do DICE for the sake of doing DICE. So if you're not able to do an optimal DICE, then please don't do a suboptimal DICE, because that is of no use and you're just putting the patient through unnecessary anesthesia. Then it is better that you do an awake, lying down, flexible scopy, which will give you an endoscopic view of the airway, and you combine that with a dynamic MRI so that you have an extrinsic view of the airway. So you have a complete view of the airway without actually doing a DICE, and you document it and you interpret it. Right? Now, this is something again I'm going to spend 5 minutes on in trying to make people understand. And once again, I'm requesting that you listen to every word that I say carefully, because otherwise, there is a misunderstanding for you to think about what I'm saying about DICE. Now, we all know that in sleep patterns change. So the question is, will DICE or will evaluation in sleep really change my surgical plan? Will it really? Now, there are multiple multicentric studies done across the world, right from people involved from Singapore, from Brazil, from Poland, from Israel, from Spain, from India, from Canada, and all of them. So this was a nice sample size of 170 patients, in which 156 did not need to go through the no DICE group. And what they found was that DICE may not significantly affect surgical success rate at all. This is just one study. There have been studies done way back since 1995 and 2000s, where some of them gave the pros, some of them gave the cons, and we found that does DICE really make that difference? Well, the answers are not very clear cut, but this is something for us to think about, that if I know that there is a lateral wall collapse on a flexible awake scopy, then there's bound to be a bigger lateral wall collapse when I do DICE. But does that mean that if I find it on a flexible scopy, I will not do a lateral pharyngoplasty? I will still do a lateral pharyngoplasty. So how has DICE made that much of a difference? Right? 2019, they did a huge study with 1,247 patients, including pediatrics, in which they showed the conclusion was that 54% of cases, the surgical plan changed with DICE, only in adults, not in children. But what is important to note here was that the plan changed only for tongue base and epiglottis, not for the palate. So for the palate, DICE was not really that informative in making our surgical planning changes, but definitely yes for tongue base and epiglottis. So my uh, message that I try to bring out, and I'm talking to the global OSA platforms also right now, and hopefully my data is ready. I've sent it for publishing, and I don't want to speak before it is officially published, but to give you an understanding, what I'm trying to say, which is being accepted by a lot of people whom I've already spoken to, is the fact that if you want to do DICE, so what happens is I get a lot of people who call me and say, Sir, we did sleep study, we did DICE, now what? So first only if you equate OSA to sleep study and DICE, that means you've not understood and used the meaning of the word DICE, right? Now, I'm not saying do not do DICE. I'm repeating, please understand and do not misunderstand. I am not saying do not do DICE. I am saying you time your DICE so that you get the maximum information for the tongue base and epiglottis at a later date. Because we say DICE is needed to change our surgical planning. To which my counter question becomes, if I have to do a septoplasty for that patient or a turbinoplasty, is DICE going to help me change my decision? The answer is a no. If I am going to do a nasopharyngeal obstruction removal, say an adenoidectomy or a salpingopharyngeal fold, do I need DICE to tell me whether I need to do that? No. If I have to do a lateral pharyngoplasty with the suspension that was popularized by Marco Barberi way back in 2014, and he published it in 2017, and we must very, very dutifully give the required credit to the people who actually brought out these procedures. Professor Vicini, who brought out the lateral pharyngoplasty, which he called as the barbed pharyngoplasty, and then Marco Barberi, who added the suspension suture, and then thereby it became a suspension palatoplasty. So a lateral pharyngoplasty with a suspension suture added by Marco Barberi as the original one. These are the people who have actually got us this surgical procedure, which I will discuss maybe in subsequent lectures some other time. But when you have a procedure which lateralizes the pharyngeal wall and raises up the palate with suspension, then you don't need to have any decision making to be done for the palate. Which means what? The logic is that if I clear my nose, nasopharynx, and palate, and I've opened the upper airway nicely and properly, then because of the Bernoulli's phenomena, the entire collapse of the tongue base and epiglottis will change. So, when you really need to work on the tongue base and epiglottis, that is the time when you need DICE. Not right at the beginning, not before a septoplasty. Except, and I'm repeating myself very clearly, except if you are doing a septoplasty under GA and just before GA you want to do the DICE just for noting it, then that is fine. That is justifiable because you're not doing a separate procedure and you're not using the results of that procedure to say that, okay, I was going to do a septoplasty, but now I'll do a pharyngoplasty instead. So you're still going ahead with the septoplasty. That time DICE is justified. And then the second time when you should be doing it is when you have already cleared the upper airway. One last important point for DICE would be that yes, for a patient who comes to me from out of country or out of Pune city, and I am tackling a multi-level obstruction in one sitting, and that patient is not able to come back to me after every 2 months and things like that, there a DICE is justified as a first step. But if you're going to do a multi-stage approach, then it does not make sense to do DICE first. You can always do it after you open up the nose and the nasopharynx and the palate. Now, this is a very, very important message that I would like to take out to the people because this is logical, rational, And hopefully very soon as my data is published, I will try and give it out to everybody. And of course, I will be putting out on various platforms where I'm talking. The other thing that has now come out with DICE is a SAM device. This is my friend Rodolfo Lugo from Mexico. Now, this is a device whereby they put in and measure the expansion of the mandible or the forward pull of the mandible with the device. I'll show it to you. And on the screen, they see how much is the pull forward of the tongue base. So this is the device where they have a measurement, and as they pull open the mandibular device and the mandible gets pulled forward, the tongue base comes forward, and that is seen on the screen when they're doing a dice. And based on this, they are able to measure the diameters or the distances that are needed. You can see this tongue base opening up when they open the dice thing, open the SAM device. See that? So this helps in finding out exactly the measurement of the uh, mandibular device that is needed. So if you see what he is doing, Rodolfo has sent me this video, and with kind permission, I have put it up, acknowledging him. We should avoid plagiarism at every stage. Please give due credit to the people who are doing this work and bringing it out. So a dice is being done. You're examining the BIS scores as exactly what we need, around 62 or so. And then they will put in the SAM device. You will be able to see that here, right? And then they expand the mandible or pull up the mandible forward with this, and they are able to measure on this how many millimeters of expansion that you need. Now, unfortunately, the SAM device costs quite a bit in India. It's almost about 1.6 lakhs or something. And because for ENTs, we don't really need it unless you are working with an orthodontist or a dental person and you want to make mandibular device. But I've just given it to you for you to understand the importance of it. So basic consensus when it comes to evaluating the airway would be a dice, but time it like the way I said. Or like I said, you do an awake FNLP in a supine position, which will give us the endoscopic view of the airway, and a dynamic MRI will give us the extrinsic view of the airway. So what is the final protocol after understanding all these evaluatory things that we do? So you do a good history taking, figure out whether you need a sleep study, whether you need a level 3 or a level 1 or a level 2. You do a clinical evaluation, you grade it roughly with the Friedman scoring. If you have the scope in the OPD, you do it there and then, or you call him to your endoscopy room the next day and do it. Before the patient leaves, also get a sleepiness scale form filled out. This is only for documentation and MLC purposes because it gives you an idea of the sleepiness score of the patient. And at the same time, schedule a CPAP trial after the sleep study. It is very important to do a CPAP trial for two reasons. Till such time as we are able to prove that CPAP is not the only gold standard, we still should do it so that if the patient gets an idea of the CPAP when he comes back to you, if he is not happy with the CPAP, he is more willing to listen to you. So it works in your favor if you do it that way. But before you do a sleep study, I have always been harping on this very, very categorically. Don't rush for sleep study, don't rush for DISE, go slow. It is very important that you treat underlying allergic rhinitis first because it's going to give you a very bad result on your sleep study. And then your diagnosis can go completely wrong. From mild to severe, it could become. So treat the associated medical conditions. If there's an asthma, that needs to be treated, AR needs to be treated. Then you do a sleep study, fill out the forms, then you do the evaluation of the airway, read the sleep study yourself, correlate it with your clinical findings, and then go in for a counseling session with the patient. In this counseling session, what becomes important is for you to understand the patient risk to benefit ratio. I may be a very confident surgeon and I know very well, okay, I can do this surgery and this patient will improve. But if the patient is not willing to take the risk, you cannot force the patient. You should have, today is the date of medical evidence based medicine, and you must have various data. You must understand the questions that are asked to you by the patient and respect the patient's choice and comfort level. Now that becomes a part of the patient, but also introspect and see your own training and expertise. If you've not been able to understand anything, please turn to your colleagues or your seniors or somebody who is there who can help you and guide you with the understanding of what investigation you've done and how you should interpret it. Equipment and technology is something which is individually based. It depends on what you have and what you don't. But you can even do it with cold steel. And the post-op backup becomes very important when you're dealing with OSA patients, right? Now, it's also important in your first visit only to counsel about success of treatment. Success of treatment does not necessarily mean complete normalization of AHI. Even if you downgrade the disease or you make the patient CPAP compliant or you improve his quality of life as a first step. So if the patient is not able to tolerate CPAP and you do a septoplasty and he starts tolerating CPAP, he will be better in a situation to lose weight and then you can do your palate surgeries later on. So it's important when you deal with your other colleagues because these are the questions that are brought to you at all times. People will ask you, oh, your surgeries failed. These are statistics which I'm showing you, which are not our statistics. These are statistics from the chest journals. So if you look at the CPAP failures, they have two types of failures. Initial acceptance failure is also very high,
Italy Jordan.
and long-term compliance failure is also very high. So when something
Namia.
like this happens, then you're not able to
Namia.
justify
The
the
story.
use of the CPAP.
Oh,
Similarly, they say that the treatment of the surgery is a failure in the long term. For that, you have to understand two things. For example, I operated on a 30-year-old patient maybe 20 years back, and the patient is doing fine. Now, when that patient after 30 years becomes 60-year-old, he is going to have laxity of the muscles and he's going to develop some kind of a sleep apnea. Now, in such a situation, can you turn around and tell me that the surgery that I did 30 years back is a failure? That doesn't work because if the patient has been good for 30 years and has been CPAP free for 30 years, then why is that surgery called a failure? Then that surgery is not a failure. So you have to understand these concepts before you can talk to your other colleagues in the non ENT fraternity so that you are able to justify what you're doing. So it's not CPAP which is the final answer. It is not surgery which is the final answer. You have to tailor make your treatment protocols, but knowing fully well that there is no medical treatment. It's, of course, lifestyle issues come into the picture, mandibular devices come, and surgical treatment comes. The only reason why we got a bad name
Nela,
was
Nela,
because
Nela.
we did not understand the importance of the multifactorial etiology and we did not accept the multi-level approach. We only kept on doing palatoplasties and left it at that. And the fact that we as surgeons were a bit knife happy and we landed up operating on a lot of patients, which was where what not the right thing to do. So your choice of procedure, and please note this slide of mine. I have first put patient profile over there. I have not spoken about surgeon profile or the surgeon skill because it is important for you to choose the procedure based on the patient profile. What is his education level? What is his motivation? Is he from in town, a lot of outside of town? What's his socioeconomic status? Does he have the motivation to follow up and everything to be done? Because only then, based on your polysomnography and your MRI or a DICE, will you be able to decide on the choice of procedure. And after that would come the surgeon factors, where your knowledge, your expertise, your availability of equipment will come in. But most importantly, once again, the surgeon should take into consideration that it is the patient's risk taking ability. And everybody today is moved from open cholecystectomy or laparotomy cholecystectomy to a laparoscopic cholecystectomy. So the similar thing applies to OSA surgery also. So if I was to give you a broad surgical candidacy, just a broad one, not very specific because each case is different. So if you have primary snorers is a good surgical candidate. People who have failed CPAP are good surgical candidates. Low BMI, AHI does not matter, but anything between 5 to 15, these are very good candidates for surgery. But as ENT surgeons, we must understand that this is obstructive sleep apnea pathophysiology. There is so much in the pathophysiology. And as ENT surgeons, we are only directing ourselves to the obstructive element of the entire disease. So don't try to become heroic and try to do things, because this all that you see on the slide is not under our control. So you have to be very selective when you're dealing with surgical intervention, which is where things went wrong. So, ladies and gentlemen, whoever are watching and who have spared the time, I repeat what I said at the beginning. Surgeries for OSA are not very technically demanding, but the application of the mind and the selection of every patient is very, very important. I don't know if you can hear this video, but I'll just play it.
See you again. Cheers. Anything else? Excuse me, madam. This might do the trick. Oh.
At Caltex, our staff will do whatever they can.
Thank you so much. You're welcome.
To help make your life a little easier.
If a person tried to help,
Oh, I see.
the person tried to help, his intention was right. He diagnosed it that the wheels were making sound, whereas actually her knees were making the sound. So he did the wrong thing. So please do whatever you can with whatever you have, wherever you have. You don't have to send patients to tertiary centers all the time. 18, 20 years back, I used to speak a lot more and louder, but I think over the time, we do realize that there are limitations to the surgical interventions, but they have very good results. When I speak about surgical techniques and talks, that time I will show you the results very well. So thank you very much, everybody, for listening in. And I hope people have been able to pick up at least the basic understanding and the evaluatory procedures. Thank you very much once again, Dr. Suresh Kumar, sir, Dr. Manoj, and I see a lot of other people joining in, and the office bearers of AOI Kerala for having me here. And I'm open to questions as and when.
Thank you, sir, for your excellent presentation.
Thank
Actually,
you.
24 years back, when I did my MS, my thesis topic was on OSA.
Oh, wonderful, sir. I would love to read your thesis. I would really love to read your thesis.
That time, we didn't have the full polysomnography. We had the limited channel polysomnography only.
Correct, sir. We have come a long way since then.
Yeah. So there is one question from one of the participants in the chat box. Should we always do polysomnography as part of evaluation, or screening sleep study is enough?
No, so when you start, like I said, if it ideally on a scientific platform, the answer would be always do a polysomnography. But I am a very practical person. For all those who know me over the years, you have to understand that everybody doesn't have access to level 1. So at least do a level 3. Do not start doing sleep work without level 3. And I gave you the indications why you need to shift from level 3 to level 1. If ever you have a patient where the level 3 reports are not matching the clinical symptoms, or for that matter, you have some comorbidities that are existing, then in that case, always try to do a level 2 or a level 1.
Okay. Sir, in your cases, is there any correlation between the short neck and the lateral collapse?
So short neck and not lateral collapse per se, but obviously short neck is going to give you more of an AP collapse, because short neck generally has a thicker or a rather wider neck to it. So by and large, the lateral collapse may not come to that level, but an AP collapse becomes it. But sir, to tell you honestly, that's a very interesting question. I mean, if at HOD level, sir, I would request you, and I will also think about giving some students a thesis to try and find out if there is a correlation, because we don't have any papers to say this.
Okay.
Logically speaking, yes, but I think we don't have anything.
In your patients, do you advise weight reduction before surgery, sir?
Always, sir, always. Weight reduction is first counseled. I did not put that here, is the first thing. And when I see the sleep study report, and if the BMI is on the higher side, I do not do even a simple radio frequency turbinate. I first motivate the patient to have lost some weight. He has to
O-
come back to me after 3, 4 weeks by losing at least 2 kilos of weight. Only then
Okay.
I know this fellow is motivated, and then I will do something.
Okay. Actually, in my thesis, actually, in that study, because of snoring, there was two divers also.
Yeah, I said
40 patients.
I would love to connect with you and have that thesis sent to me if you can. I would love to read it, sir. I want to
Ah,
read it.
okay, okay. I'll send it, sir.
Yeah, definitely.
Any other questions?
Sir, I can just see some things on the chat.
Chat.
I will just go through it and tell.
Dr. Reggie, can you go through the chat?
Yeah, I'm just going through it, sir.
Okay.
So, Dr. T.A. Rahim, thank you. Thank you, sir, for being there. Dr. Joycey, thank you, sir. Dr. Thomas, thank you. Dr. Rahim has asked, will you be able to diagnose multi-level obstruction in OPD by flexible scopy? Sir, yes, definitely, but not to the extent where you can base your decisions just on an awake scopy. But the minute you do an awake flexible scopy, you will obviously be able to see all the nose, nasopharynx, salpingopharyngeal fold, the palate, AP, lateral collapse, as well as the tongue base and epiglottis to a certain extent. So you will know for sure that there are multi levels, and then step by step as you go across them, then when you're getting more invasive, that's when you do the dice. When you're not getting invasive, then a flexible scopy suffices initially. Dr. Shajim, thank you, Dr. Shajim. Dr. Matthew also. Dr. Matthew is asking me to explain Muller's maneuver. What exactly do you tell a patient? So Muller's maneuver is nothing but, when your scope is inside, we ask the patient to kind of we block his nostril with our own hands and ask him to do a kind of a Valsalva maneuver. So that way there's a negative section that comes in and the tongue base gets pulled up, if at all there is a tongue base issue, and that you can see. Now, again, these are very clinical approaches, but they do give us a very good idea whether tongue base is involved or not. But don't base your decision only on a Muller's maneuver. Once you've finished with the nose, nasopharynx, and palate, that time do a dice, see what is the tongue base issue, and then go ahead. Dr. Joel Matthew is asking about if the patient's aim is to cure snoring, how do you counsel and approach the case? Very good question, Dr. Matthew. This is the first thing that everybody comes and asks. So, in my first interaction with the patient, only when I've explained to them about sleep study and a flexible scopy, the first thing I tell the patient, and I repeat this again if he comes back with his wife or anybody else, to the fact that we are not here to treat your snoring. By now, with all my counseling and everything, you have understood that snoring is one of the symptoms of a disease called sleep apnea. And we are here to treat your sleep apnea. And because you have multiple levels of obstruction, once we clear all the multiple levels of obstruction, that is when your snoring will go away, not before that. And the second thing I counsel them, because a lot of patients will ask you this, oh, he was snoring very less earlier, now he's snoring very loudly, and then sometimes the snoring becomes less. So I explain to them very categorically that the decibel sound of snoring has got nothing to do with the severity of the disease. That's just a subjective symptomatology that the patient has. A patient can be snoring very loudly, no problem, very softly, no problem. Snoring is only telling us that there is an airway obstruction. These are 2 points that I clarify very first in the first consulting itself. Dr. Rahim, thank you, sir. Thank you. Dr. Subhesh Kumar, sir. Is there any correlation with anterior larynx with OSA? Definitely, sir, because if you have a very anterior larynx and the epiglottis is not falling, that will be a little to your advantage, right? But if the epiglottis is falling, then that would not be very good for you. Dr. Pratesh Mohan. Good evening, Dr. Pratesh. Does Barb suture give foreign body sensation as a complaint? Initially, yes, anything that is kept there initially will give always, Dr. Mohan, but I think as you get, time goes, it kind of just settles down. Dr. Sahir wants to know the percentage of success with COVID in barbed sutures. How do you define percentage of success, Dr. Sahir? So it eventually depends on the number of cases that you do. Again, the question is what success are you looking at? So the barbed sutures are always holding very well and they don't really give away, barring a few here and there, whatever. But I think, irrespective of the suture, what is important is your technique and what are you doing. Because, see, I said this in a lecture of mine where I talk about the myths or clearing the myths of barbed pharyngoplasty. So I tell them very clearly that this word barbed pharyngoplasty is just a fashion. It is just a pharyngoplasty done by a barbed suture. What is important to understand that the procedure is a lateral pharyngoplasty where you are picking up the palatopharyngeus and suturing it onto the pterygomandibular raphe laterally. So you can do this with any PDS suture also. You can even do it with a Vicryl suture also. It doesn't really matter. The barbed was how Professor Vicini started it, and it became popularized as the barbed pharyngoplasty. But the actual procedure is a palatopharyngeus repositioning suturing. So it's a repositioning of the palatopharyngeus. It's a BRP, barbed repositioning pharyngoplasty. And with this, when Marco added the suspension slings, so it became a barbed suspension pharyngoplasty. So a barbed suspension pharyngoplasty includes a barbed reposition pharyngoplasty with added two suspension sutures. So there's a BRP and a BSP. That's what it is. Dr. Rahim is asking, how do you approach a lean patient with snoring? Sir, exactly the same way as you approach any other patient. Even if it's a lean patient and he's snoring, means there definitely has to be an obstruction somewhere, which we need to figure out. So you do the same things. You do a sleep study, you do a scopy, you do a dynamic MRI if you need, or you need to do a DICE when it is needed. Somebody else has asked, do we need to decongest the nose before DICE? Well, I frankly do not do it. There are some people who tend to think that we can't pass in the scope. Now, I tend to use a pediatric bronchoscope with a suction channel. That is it's a very beautiful scope, 2.4 mm in size, and that passes very easily because the minute you go to decongest the nose, you're putting in all the nasobronchial reflexes in place, and that sets into the picture a very different airway dynamics. So I don't prefer to decongest it. I just straight away pass the scope. And I think for the audience who's trying to enter into sleep apnea, one of their biggest queries and questions that come to their mind is, what scope do I buy? So if you are in a bigger institute where you have multiple scopes, fair enough. If the hospital is buying it for you, very great. But if you have to choose only one scope, then my strong suggestion would be a flexible pediatric bronchoscope of 2.4 to 2.6 mm diameter with a suction cannula in place, with a suction port in place. That one will serve all your purposes, adult, pediatric, even for your bronchoscopy and everything in your institute. Dr. Suresh Kumar sir has asked, can we do septoplasty and tonsillectomy after DICE immediately? Sir, yes. If it's obvious that it's a grade 4 tonsil and is a very badly deviated septum, and that is your first step as a part of a multi-level, and since you're already doing it under GA, then you can definitely do a DICE before that and then carry forward with the septoplasty and tonsillectomy. Right.
So if there are no other questions, I think we can wind up the session.
Some more
Suresh sir?
is there. Some more is coming.
Coming. Okay,
I
okay.
see one which is, what are the immediate difficulties or complications with epiglotectomy or epiglotoplasty? This always happens because when I'm trying to focus on investigation and evaluation, this is how our surgical mind directly jumps onto surgical planning and treatment. So I'll just still answer it anyway. There are no immediate difficulties or such as we do every typical laryngeal work. As long as you're able to keep the larynx and the airway intact and open, there's not much that can happen because nowadays we are using coblators. So there's hardly any bleeding or anything that happens. And if not, you can always use a laryngeal mask if there's any kind of airway compromise that could happen. Dr. Prashant is asking, during DICE, some patients desaturate faster, difficult to differentiate between V2C and V2AP. How to tackle this? Go for anterior palatoplasty or barbed? Okay, Prashant, that's a very good question, but see, V2C and V2AP are very easy to figure out because AP will be seen. It's a complete AP. You will see the lateral wall separate. You will not see the lateral wall collapsing. In a concentric one, you will see both of them collapsing. So I don't think it's very difficult to differentiate between the concentric and AP collapse, right? Because there's always going to be AP. We are talking about V2AP, okay? You're saying a complete AP collapse. So when there's a complete AP collapse, the lateral walls are not going to be able to come close. It's only going to be AP diameter and not the lateral one, right? So in such a case, an anterior palatoplasty definitely will be a better option unless and until you go below and you find that the lower lateral pharyngeal wall is also collapsing mediolaterally. Then in that case, a BRP becomes a better option because you are then able to attend to the lateral wall as well as the AP pull on the BRP. That's why BRP and BSP have become the final, workhorse for palatal work. I hope that answers your question, Prashant. That's a very, very good question, though. What is the ideal tool used in palatal surgery, coblation or radiofrequency? Sir, that age-old saying, that's not my saying, it is the saying which says that it is the fool behind the tool that matters. It's not the tool. So ultimately, both the devices that you spoke about, coblation and they work on the same principle of radiofrequency ablation, and it really doesn't matter. Although I would say that if you're talking about adenoids, their coblator is way, way better. That goes hands down because coblator is a very good tool for tongue base and adenoids, sir, because it removes volumetric excision, whereas the radio frequency does volumetric reduction. So for turbinates, a radio frequency would be better. For a palate, maybe a radio frequency would be better. But for an adenoid and a tongue base, I would strongly recommend a coblator. Maybe for the larynx also, the radio frequency is better because the probes are thin. Coblator may not be all that great.
Thank you.
Thank you, sir. I think that kind of finishes the questions. Dr.
Any more
Reggie,
questions, Reggie?
all over to you, Dr. Reggie.
Yeah, yeah. All
Thank you.
questions are over, sir.
Thank you,
We
sir.
can wind up the section.
Perfect, sir.
Thank you, sir,
Wish you all
for
a
that
very
excellent
good night.
presentation.
Thank you, sir.
Mohan, you can say vote of thanks. Mohan, please.
Yeah.
Yes.
Dr.
Thank
Mohan,
you.
thank you
Thank
very
you
much,
all.
Dr. Mohan, for having me here. I would
Oh,
love
it's
to
a pleasure.
physically come to your conferences too sometime.
Do
Fingers
please.
crossed.
Do please.
Fingers crossed.
Thank you all for attending in spite of your busy schedule. It's getting late, so good night. And we'll meet very soon for our next webinar. Thank you.
Thank you very much, sir. Good
Thank
night.
you, sir.
Thank you.